I really kind of liked this topic. I find myself very interested in things that are just really relevant to day-to-day practice. It's nice to hear statistics or the latest treatment for different things, and I would certainly like this to be interactive. So as much as we can address questions, we'll allow some time for questions at the end. And Chris, if there's a way for people to interject questions, just let me know. So basically, we will be talking about just the basics of how to recognize changes in patients, which, as everyone knows, sounds simple when you hear it in a lecture, but when it's in the real world and it's an acute situation in the hospital, it's stressful and it's hard to know exactly how to make sense of things. So we'll try and just break that down. And to some degree, we'll have to understand a little bit about how stroke works, and then it makes sense to understand what the presentations of the different symptoms are. I always think it's good to get a little refresher on the huge impact that stroke has on our community. There is, 800,000 strokes a year. It's the 5th leading cause of death, but more importantly, it's the leading cause of disability. And, if you ask patients, very often they're more fearful of being disabled or incapacitated, more so than even the risk of death sometimes. The incidence is 25% in your lifetime. So you've got a 1 in 4 chance of dealing with this yourself. And the vast majority of strokes are going to be ischemic or blockages of a blood vessel, much in the way you'd see with a heart attack. But about 50% are hemorrhagic, so they're bleeding. And technically, stroke refers to either type. And that'll be one of the first things that we need to do to try and sort out how to treat the patient is, are we dealing with a bleed or an ischemic or lack of blood flow problem? I like to kind of separate risk factors into 2 main groups. I would consider these risk factors to be the really most potent risk factors. So the things, unfortunately, these are things that we can change or we can modify. And there's a thought that we can really avoid or prevent most strokes, which is interesting to think about. So high blood pressure is a big one. I always mention that it's not the acute high blood pressure that causes the stroke. It's the accumulation of years and years of being hypertensive that causes thickening and damage to the blood vessel walls, and then that presents the risk for stroke. So again, getting a jump on prevention is a big deal. But in the acute setting of a stroke, having a high blood pressure is actually beneficial in the short term. So we'll get into that a little bit more. Diabetes is a terrible disease, and the brain and the blood vessels are also affected by diabetes. So it tends to affect the smaller blood vessels in the brain, much like hypertension does. And I would say smoking is in that category as well. More people are going to be affected if you smoke in terms of heart disease or stroke than you would from lung disease or cancer. Atrial fibrillation is a big one, and that's also important because we treat that very differently. So we're going to find that figuring out whether this is a stroke that came from the cerebral circulation or if it's an embolus that came from the heart is a big decision tree we'll have to face right away when we're treating patients. And then general hypercoagulable states. There are certainly the genetic predispositions that I think most of us are familiar with, but those are really uncommon. So the more common situations are, not only pregnancy, but the postpartum period, estrogen replacement or the birth control pill. Malignancy usually is, sometimes we'll find out someone has a cancer based after we discover their stroke, and then there's a pattern that suggests that we're hypercoagulable. And then certain diseases like sickle cell or polycythemia can be a situation that promotes stroke as well. So other risk factors are important, but they're just not as potent. And again, these are some of the less modifiable risk factors. Certainly you can't do anything about your gender or your family history, but there are some things you can do. So cholesterol management is a factor for stroke, but not quite to the degree that it is for the other risk factors and for heart disease. And I think little known risk factors like having migraines and migraines with aura actually increases your risk as well. And then some unique situations like cervical trauma can predispose you to dissection, which is a special form of stroke that we'll see a little more often in young patients. So the sources of the stroke, when I evaluate a patient, I'm really trying to figure out, after I've determined that it is a stroke, which is sometimes not that easy, but once we have, I want to know where it came from. And then I can determine, what the patient's risk is, how to manage it, and how to reduce their risk in the future. So thrombosis, meaning we developed a clot due to irregularity in the blood vessel walls or a variety of situations that occurs in situ or right within the blood vessel itself. This can occur in larger vessels or smaller vessels. We can deal with large artery like carotid stenosis or plaque formation, and a ruptured plaque can result in an acute thrombosis or sometimes artery to artery emboli. And then there's cardiac embolism, as I mentioned, and then the hypercoagulable states. So this is kind of just a nice little visual summary of the cerebral circulation. If you figure the heart is down here, so anything that affects the or clots that develop in the heart, you can understand how immediately we're going to go into the cerebral circulation first. We can have emboli that go to other parts of the body or the kidney or the liver, but or extremities. But the first stop point is the cerebral circulation. And just by the flow dynamics, the most common scenario is for a clot from the heart to run up through the aorta and end up into the left side of the circulation. So your left middle cerebral artery stroke is the most common, but it could happen in any one of these vessels. And it can either go into the posterior circulation or in the anterior circulation, and we'll emphasize how that's important to differentiate as well. These are the major arterial distributions. So the red is the middle cerebral artery, and this is the most common area where we'll see stroke. It is also encompasses the largest area of the brain. So that's by far the most common. We'll probably see posterior cerebral artery stroke, so that's the green area. This will affect the occipital lobe and the medial temporal lobe. And then the anterior cerebral artery, which is a less common area of stroke, will affect the very medial aspect of the hemisphere, and that usually presents with a predominant weakness in the leg. So the acute presentation of stroke, I think from a general perspective, the important thing to remember is, as the name implies, it's an abrupt onset of the symptoms, at least within a few minutes. So the name stroke basically came from the antiquity, when it looked like a stroke of the gods would affect somebody. And that's why we still call it that. Brain attack, of course, means the same thing. So typically a stroke, and I'm going to focus right here on the anterior circulation, is something that affects the hemisphere. So we're going to affect one side of the body. And that's an important theme when we're recognizing stroke and trying to differentiate that from confusion or syncope, is that, a clot affects one blood vessel, and there's no one blood vessel that affects the entire brain. So it's always going to affect one side or the other. So we can have hemiparesis or weakness of one side. It could be loss of sensation on one side, which may also be tingling or a kind of a positive phenomenon. We can have neglect, where we're relatively unaware of one side of the body, or sometimes not even realize that we have a problem, which is what agnosia is, that you're not aware that there's even a problem there. So you'll see patients that don't recognize their side of the body, or they'll find their arm on their chest and think it's somebody else's. Aphasia refers to a language problem. Always need to distinguish this from dysarthria. So dysarthria is a slurring of the speech or inability to form words mechanically with the lips and the tongue, whereas aphasia is either a problem with generating words. I can't come up with the right words. My speech is disfluent. It's choppy, or I can't understand what people are saying. And it's almost like you're dealing with somebody who doesn't recognize the language. And very often it's kind of a combination of those. So, but either way, there's ways to quickly test whether we're dealing with some sort of an aphasia. Facial weakness. Realize in stroke that weakness that comes from the brain will cause weakness mostly in the lower part of the face. So it typically doesn't affect the forehead as much, but you'll see a drooping or a flattening of the fold of the cheek or the downward trend of the lip on that side, and then the inability to activate it when they smile. And a sudden decrease in your level of consciousness can be associated with stroke, but it's very uncommon. So very large strokes or strokes that affect the basilar artery, in theory, can cause loss of consciousness or acute sleepiness, but it's less common. And if it does, you'll see it affect something else as well, meaning you're not just get sleepy, but both arms are working well. If you've got a big enough stroke to make you sleepy, you're going to have a big hemiparesis at the same time. So these are also acute stroke symptoms, but this affects the posterior circulation. So this includes the brainstem, the occipital lobes, parietal regions, and does not involve the carotid circulation. This is primarily the basilar and the vertebral arteries. And this is where you're going to get your incoordination or ataxia, vertigo, which is technically defined as a sense of movement or spinning, as opposed to just lightheadedness. Dysarthria, again, can be affected in the posterior circulation with a slurring or imprecision of speech. Again, a sudden decrease in loss of consciousness, uncommon, but if you include your basilar artery, you can affect the entire brainstem at once. And then visual field changes. These are ones that patients themselves will sometimes be really unaware of. And so you really get a sense of this in the history when they, were driving and suddenly they, ran into the curb, or they hit a mailbox, or they bumped into the wall. They will lose vision on one side, but as opposed to having a problem with the eye itself, where you'll see black or part of the vision will be gone if you affect the blood vessels of the retina. Here, the brain just doesn't process what the eye is giving it. And so you'll have a problem with awareness of what's going on one side. And it affects the half of the vision in each eye. So really the entire world on the right side, for example, is going to be something that will be affected for the patient, but they may not even be very aware of it. And then double vision is almost always a brain problem. So it can be due to mechanical issues with the eyes, but the abrupt onset of that is really stroke until proven otherwise. And you can lose vision in one eye, which is returned if it comes from the carotid. It's referred to as amaurosis fugax. But again, it's not affecting the brain. It's an embolus that goes to the eye, and most often the ophthalmic artery. So one of the things that we're trying to emphasize these days, which is in large part due to our ability to now treat strokes by going up and retrieving the clot out of a large vessel. So this has been a therapy that's been with us for a few years, but it's really been more of an approved and streamlined process just within really the last 3 or 4 years. And we have the ability to do this, but only in large vessels. So this would be the carotid artery, the middle cerebral artery, the anterior cerebral artery, and really it's only in the anterior circulation. So that's something that we'll have to keep in mind when trying to sort out stroke. So typically when we're trying to determine, is this a big vessel, is this a large vessel occlusion, there'll be certain symptoms, and basically your more severe symptoms will be the ones that will tell us whether or not this is potentially a large vessel occlusion. And if we think it's possible, then we have to go through the workup to really make sure that we're evaluating the patient to see if they would be a candidate for thrombectomy or this clot retrieval from a bigger vessel. The RACE score, RACE, which is really not important for us, hospital clinicians to be concerned about, but the emergency medical personnel will use this. And when they see a patient in the field, they can determine by this score if they would be potentially a large vessel candidate, because we have to be thinking about that right from the get-go. So typically this is going to be a major hemiparesis, face and arm, or face, arm, and leg. It could be language problems. It could be gaze deviation, which means that their eyes will tend to fixate toward one side, and they oftentimes cannot overcome that volitionally. And then there's the agnosia, or the neglect, basically. And this is something that's going to make someone kind of unaware. And they may actually have some decent strength on that side, but because they're really unaware of that side of the body, they won't move it on command. And you're all familiar, hopefully, with the BFAST acronym, which I think is useful. And I think patients, take this to heart pretty well. This is a big area of potential education. So patients, I would say almost the majority of the time, they come in with their stroke and they weren't really aware that what they were experiencing was potentially a stroke symptom. And so obviously it's good to educate them after they've had a stroke, but we are going to continue to try and get the word out so patients are aware of these symptoms. But it basically encompasses the balance, which is ataxia, the eyes, which could be double vision, loss of vision, face weakness, arm or of course leg weakness, speech trouble, and then T is for time, which means we need to get into the emergency room as soon as possible. The time frame for TPA is 4.5 hours, and for thrombectomy is 24 hours. All right, so this is one of those things that I think we all face as hospital clinicians is this change in the patient something that could be a stroke? And of course, if it is, then we have to go down that pathway with a rapid response and a stroke alert potentially. So, what is an abrupt change? Obviously, it can happen fairly suddenly, but it's still going to take several seconds or a minute or two. And then sometimes it really evolves over 10 or 15 minutes. Certainly, strokes can fluctuate. So the eventual presentation or the most severe presentation of a stroke can take, hours potentially. But anything that happens fairly quickly is at least something we have to consider as a possibility. Now, other things neurologically speaking that cause acute change in neurological status would include seizures and potentially even complicated migraine, and then of course loss of consciousness due to syncope. But there's not that many other problems. So stroke is really the thing that we need to think about first because it's the most serious. So when we see a change in the patient, we should think about what would be the more common or simpler way to explain what might happen or what might be happening. So if we have a big change in the blood pressure, we just gave them a dose of sedating medication. Did they just spike a fever that we weren't aware of before now? Did they just get up to the bathroom and on their way there began to feel lightheaded and dizzy, or maybe even passed out, such that we're dealing with a form of syncope? So those are things that should be considered. And then back to what I mentioned, is this one-sided? So is the face weak? Is one arm working and the other one not? Are we numb or tingly or incoordinated on one side and not on the other side. And then obviously, without even talking to the patient, you can sometimes appreciate if there's weakness in the face. And it's not really that important to figure out which side is the weaker side, but if it's definitely asymmetric and they weren't like that before, that's significant. And then sorting out, confusion. So obviously confusion or disorientation is very common, and that can happen acutely or at least relatively quickly in the delirious patient. What is the actual confusion and what is actually more of a language problem? Confusion involves impairment of the entire brain. So if you have a medication that's sedating or causing a problem, or if you have something like a metabolic problem such as renal insufficiency or hepatic failure, these are going to cause the entire brain to be affected. Whereas aphasia is a focal or hemispheric problem involving language. So basically, when I look at a patient to try and decide if this is a language problem, I'm going to make sure they're alert. And if they're not, I'm going to be yelling at them. Maybe they're hard of hearing, maybe they're sleepy and I need to sternal rub them or give them a pinch, and continue to make sure they're fully aroused, because I can't assess language unless they're aroused and looking at me and attending to what I'm telling them. And then you can certainly just assess, is the patient able to generate speech? And if they don't do so on their own, ask them a question. Can you tell me this? And make it very simple. And if it doesn't seem like they can even do something simple, then ask them to repeat a single word such as hello and see if they can do that. And if they're looking at you and nothing's coming out and they just look confused, it very well could be an expressive type of language problem. Then you can, and that would be something to assess the expressive language, but we also want to assess, can they comprehend or understand what I'm telling them? So I want to give them a request or a command that will actually tell me if they can understand, if they're processing what I'm telling them, and if they can follow through on that command. And I want to do it without showing them what I'm doing. So I can say, squeeze my hand, but if I'm putting my hand in their palm, the reflex is to squeeze it. They've probably been doing that during the whole hospitalization. So I don't know if that's a very accurate way of testing that. But if I simply, without showing them with my hands, can you move your left foot? Can you hold up your thumb on your right hand? And then you can get more complex in the questioning. And if we're having difficulty with that, then maybe they're attempting to do it, but they're really not following through accurately in what I asked them to do, then that would really suggest more of a language problem. Whereas most of the time when we do see confusion in the hospital, they're going to be sleepy. And again, if they're sleepy, it could be a big stroke, but more likely it's due to medication effect or other metabolic factors or something that might be responsible for their delirium. So we also can see a worsening of an existing deficit. Sometimes if they've had a stroke or if they've had a language problem, if they're sick or ill, sometimes that deficit gets worse. It doesn't necessarily mean we have a new stroke or insult, but it is something that may look like a stroke. And so, keeping in mind, if it's within the distribution of their old stroke, I'm going to be a little less concerned about it. But, still something to improve, and certainly we can extend a stroke as well. And then, when we run into the room or we find them and they're weak on one side, it's possible that we could have missed a seizure. So if we don't see the acute phase of the seizure, sometimes all we'll see is the postictal deficit, which is weakness on one side if it affects that area of the hemisphere, or if it affects their language. We'll see this with brain tumor patients, where if the seizure occurs, it comes from the tumor, but that's also the side of the brain that's already weak or maybe not functioning properly, and it will worsen that previous problem dramatically, and it will be indistinguishable from a stroke at that point in time. But it'll gradually improve, and sometimes fairly rapidly within minutes, but sometimes it does take several hours or the better part of a day for that to recover. And again, if you do see a decreased level of consciousness, is it associated with a major deficit? If they're not able to maintain their alertness very well, it's really not going to be a stroke unless there's a major deficit associated with it. So my suspicion for something else is increased at that point. And then one side note, but an important one, is, is the patient really being genuine in their effort and in their ability to follow commands, or are we dealing with a psychological disorder such as a conversion disorder where the patient really isn't trying to fake a deficit or to mislead us, but they really don't have the ability to move that side. However, typically what we're going to see is very inconsistent effort. The arm will be weak at one point where they can't even move it, but then you'll see them moving it on their own, or they can hold it up in other situations. They'll try, and after a great deal of encouragement, finally they can get some strength going or follow the command that we're asking them to do. Now, those are all signs of psychogenic type of weakness, which unfortunately is all too common, and that makes it very challenging to sort out what's going on. However, on that note, and this goes to treatment, but if we are concerned that someone may have psychogenic weakness, but maybe it's unclear, those patients really are at very low risk for complications from TPA. So the risk from TPA in terms of bleeding comes from the risk of bleeding. And if you don't actually have a stroke, your risk of bleeding is very low. So we're comfortable with erring on the side of treating the patient if we're not sure, even if there's a chance that this could be a functional or psychogenic pattern of weakness. So these are kind of just a list of things that can mimic stroke. I think with a little bit of investigation, we can usually sort this out. This is the conversion disorder that I was just talking about. One thing that is relatively common is a complicated migraine. So migraines can, and sometimes this can occur without a headache, but typically the aura of a migraine is the involvement of vision, flashing lights, for example, but it can be numbness on one side, it could be language. So migraine really can mimic a stroke, but usually very temporarily. So typically the time frame of a migraine aura is about 20 to 30 minutes, although it can go for more than an hour. And with that, usually there's a migraine that follows the deficit, but usually the deficit is first. And so acutely, it may be very difficult to know if this is a stroke or a migraine presentation. There is encephalopathy. So what that means is, as neurologists, this is one of our favorite terms because it basically covers everything that makes the patient confused or disoriented besides a stroke, basically. So anything that is an infection, metabolic problems such as renal insufficiency or sodium problems, electrolyte issues, and then anything that's medication related. So those are going to be things that will cause the patient to be confused and sleepy and can potentially look like an aphasia. Hypertensive encephalopathy is also one that can mimic a stroke. We actually have a patient in the hospital now. Typically, it does take very high blood pressures, over 200. But the exception is that the rate of change is what really makes the difference. And so in pregnant patients, for example, if we're developing preeclampsia, a sudden rise in blood pressure of only 30 or 40 points from someone who normally lives at 110 systolic and now they're at 150, that is definitely enough to cause changes. And so we can see vision trouble, we can see seizures, we can see mild confusion or language trouble, and it can really mimic a stroke. If we actually see areas of swelling on MRI, we refer to the process as posterior reversible encephalopathy syndrome, or PRES. And again, these are changes that are most often caused by blood pressure, but there's other things that can do it. But the nice thing about that is it's a reversible problem. And important to know because we're going to want to reduce the blood pressure, where in stroke, we're usually wanting to let the blood pressure run high. Seizures, postictal deficit, so we talked about that. Very uncommon, but venous thrombosis within the sinuses of the brain can result in focal deficits, usually with severe headache. So that's one of the things that tips you off there. And hypoglycemia can cause focal deficits, whereas hyperglycemia basically never does. It certainly can affect people's alertness and their consciousness, but it's the low blood sugars that are really more deleterious to the brain function. Vertigo is a big one that can be very difficult to sort out from a stroke versus an inner ear problem. Peripheral meaning the peripheral vestibular system. Now, normally, if we have vertigo from a stroke, we're probably going to have other problems, whether it's double vision, whether it's numbness on one side, dysarthria or speech difficulty or a facial droop. A pure cerebellar stroke could just cause dizziness. But one of the distinguishing features there is that the stroke or the dizziness that comes from a stroke is really going to be less intense than it would from an inner ear problem. So inner ear problems can come on all of a sudden, and they can cause violent vertigo and nausea and vomiting to the point where the patient can hardly move. Whereas the patient that has a stroke usually will feel very dizzy. They may get nauseated, but it's usually less intense. But when they get up to walk, they find that it doesn't make their dizziness worse, but they have trouble standing up, or they'll fall to one side or bump into the walls, for example. And usually that holds true fairly uniformly across the board. Occasionally, a spinal cord problem will cause weakness in an arm or leg more on one side than the other, but most spinal cord issues occur with both arms and legs relatively symmetrically. And then a kind of an unusual condition called transient global amnesia. And this is where patients will suddenly be able to take in new information, and very often will look confused, and they may not speak as readily, but they really are still able to get out language. There's no weakness. Everything else functions. They just can't remember things. And this also is something that affects both sides of the brain. So usually that can be sorted out, but again, some can be confusing at first. So the acute stroke assessment is something that once we've determined that we think there may be a stroke here, now we need to really pull the trigger and go ahead and work this up in a very rapid fashion. As Pam Stout always promotes, time is brain, and we lose neurons every second. So even though we have 4.5 hours to work with in terms of whether or not the patient will still be a candidate for TPA, getting it in sooner is certainly going to give the patient better results. So the sooner the better. But when we're talking about calling a stroke alert, we really need to consider the 24 or practically 22-hour time frame. So if the patient's symptoms started longer than 22 hours ago, or their last time known well was more than 22 hours ago, they're really not going to be a candidate for acute therapies. So whether that's TPA or thrombectomy, that's something that then the stroke alert is not going to be as relevant for. Sometimes that's difficult to know for sure. Sometimes the patient wakes up with their stroke. And if they do wake up with their stroke, we still take the time that they went to bed as their last time known well. There's some movement in the academic community to consider the time in those situations as midway from the time when they went to bed to the time where they woke up. We can use other technologies like perfusion imaging to determine if they're acute candidates. So that's something that isn't standardized at this point, but will be something that we'll want to pay attention to in the future. They would be a TPA candidate if their last known well was within 4.5 hours, and they're an endovascular candidate if their last time known well was in 24 hours, although practically if it's if it isn't 22 hours, we don't have time enough to work that up. So the two things that are necessary for someone to be a candidate for TPA, meaning the things that have to get done before we can administer that, is a CT and a glucose. So we technically don't need an EKG. We don't need to know their creatinine. We do need to rule out other contraindications. Are they anticoagulated? Are their platelets too low? There's a list of things that you're all aware of as far as TPA contraindications. But as far as things we have to have, as far as tests, it's the CT and the glucose. And then other assessments will follow, including the NIH stroke scale, et cetera. This is the algorithm that we use at Methodist. And I think it's one of those things that's good to familiarize yourself with it beforehand. In the heat of the moment, it's very hard to follow a decision tree like this. But it does basically step by step take you through, when was the last time known well? Is this a large vessel presentation, meaning there's a major deficit and we're at least going to be considering thrombectomy? And again, or another way of determining that would be the NIH stroke scale score that would be greater than 6. So all of this is on the algorithm and it takes you through, and we'll go into what to order. But one of the emphasis I'm going to try and make is that we need to have consideration of the large vessel process. If we do, we need to get that CTA and CTP ordered, ideally right from the get-go, so we don't have to have the patient going back down for another study. All right, so when we get a CT, I think it's always important to remember what information are we actually getting with the CT. And to be honest, really all we're determining is whether or not there's been a hemorrhage. That's the most important thing. We're typically not going to see signs of a stroke. And in fact, if we do it right, we're doing it early and we shouldn't really see any changes. These arrows and stars point to kind of vague, indistinct appearance of the gray-white junction or the sulci. They're not as apparent, so there's early swelling. We can't see the boundaries between the different structures in the brain, but for the most part, a CT is probably going to appear normal. If it looks like this, then we are too late. So this is already probably 24 to 48 hours after a stroke. You can see the demarcation of what is the MCA distribution of the stroke. We've already got swelling that's pushing the ventricle to one side. And at this point, this is why we can't give TPA outside that window, is because this area is very prone to bleed. It's very unstable. And this is much different than an MRI. So when we get an MRI, we will be able to see the acute changes of a stroke process within minutes to when it happened. So as soon as you can get your patient into the scanner, basically, if there's a stroke, we should see the changes. Practically speaking, the MRI can't be done fast enough to facilitate TPA in a timely manner. So we're still unable to rely on MRI. However, we can get information acutely in the acute setting from a CTA or a CTP. So this is how we're kind of being able to understand, is there a large vessel occlusion, and can we get actual objective data that says, yes, this is a stroke, and I know where it is. It's right there in that first section of the middle cerebral artery. With TPA and CT, we're going by symptoms, and we have a negative scan for a bleed. But if the patient has a psychogenic pattern of weakness, we're not really going to be able to see that. On the flip side, with CT angiography, we can see where the middle cerebral artery is following its normal course over here, and then it branches off into the M2 segments. But over here, we see the cutoff. And so that MCA is gone, and we're missing circulation on this side of the brain. Obviously, we can see cutoffs in other major vessels, but it gets a little harder to see out in the more peripheral areas. And really, it's these more proximal clots or thrombi that we're going to be able to extract with a thrombectomy procedure. And again, all this is kind of emphasizing why we need to figure out the large vessel situation. But this also kind of tells us what we're doing when we're working up a stroke and why we're moving fast. There typically is an area of the stroke where lack of blood flow has resulted in probable irreversible damage to a certain area of the brain. We call that the core of the stroke. And to be honest, that's going to happen within several minutes most of the time. And so the damage is done at least to some area of the brain. What we're trying to do with establishing circulation again, whether it's TPA or thrombectomy, is to save the larger area called the penumbra, which is, it's stunned, it doesn't have enough blood flow and oxygen to function, but it's still salvageable. If we could just get the blood flow back, that area of the brain should return to normal. And we have ways of determining the mismatch, or what's the ratio of the penumbra to the core. And if we have an area that's basically around 2 to 1 or 1.8, then we feel that patient would be a good candidate for a thrombectomy procedure. So this is what the perfusion study will look like. It will actually calculate the rate of blood flow into a certain area and the volume that is involved in a slower rate of flow, and it'll calculate what is the irreversible area, which is the red infarct core, and what is the penumbra, or the area that is potentially salvageable. So this is really a neat thing that we have now at our disposal, and we've just introduced this at Methodist fairly recently, and it's been in other academic institutions for a little while, but it's still a very recent tool that we have at our disposal now. The studies that supported stroke or thrombectomy really showed a very impressive improvement. So that's another motivation to recognize these acute LVO or large vessel presentations, as opposed to TPA, where we're seeing a 30% reduction in a deficit in 30% of the people in 3 months. We can get a very impressive reduction in mortality and in morbidity. And sometimes these are folks that have a complete hemiparesis, they've got complete language impairment, and they may not get 100% recovery, but they get usable function of their arm and leg, and their speech comes back. And so that is a huge save. And so we have the opportunity to really make a big difference in these patients. Keep in mind that this does not exclude TPA, so we can do both of these therapies in tandem. And in the studies, only a minority of the patients did not receive TPA first. So a couple just things to keep in mind when we're thinking about the acute stroke presentation. When we're trying to go through those exclusion criteria, the thing that I see very often is that the patient just came out of a major cardiac surgery, and well, they're obviously not a TPA candidate, so I guess we're done. And the thing to remember is that if patients are not able to be a candidate for TPA, they can still be a candidate for a thrombectomy. So whether they just had major surgery, whether they're on heparin or Eliquis or anticoagulated for any reason, or they just had a brain bleed a week ago, all these patients are still candidates where we could go up and potentially retrieve that clot if we're within the right time frame and if we've got a lesion that's accessible. And because of that, we may not know if this patient for sure is going to be a TPA candidate or a thrombectomy candidate, but if it's possible, if there's any chance that this is a large vessel presentation, then again, let's get the CTA and CTP right off the bat with the CT. And at least at Methodist, we have our rapid response nurses have the ability and the blessing from our hospitalist to go ahead and get that ordered before the patient may have been assessed by a physician. And again, time is brain. Millions of neurons are lost every minute. So the faster we can do this, even though we still have time within the window, we still need to be moving fast. So after the stroke, I'll run through this fairly briefly, but we want to make sure that we're optimizing the recovery, which means we're allowing for permissive hypertension. We're not letting their glucose get excessively high. If there's a fever, we need to treat it. If there's a swallow problem, we need to be aware of that and keep them NPO until that gets cleared. And then we move toward investigating the cause of the stroke. And the blood pressure parameters that we use are typically within, change depending on what we've done. So if it's a hemorrhage, obviously we're worried about keeping the blood pressure low, so below 160. If it's a stroke, we really want to let that blood pressure ride as high as 220 over 220 before, or 120 before we treat it. And then if we've just given TPA, there's the post-TPA or thrombolytic guidelines that we use, and less than 180 over 105 is the numbers that we're looking for. All right, so once the patient's had a stroke, of course, that doesn't prevent them from having more acute neurological changes. And I think it's another opportunity to kind of think about, what are we going to do? Maybe they've had the stroke, we're on day 2 or day 3, they have changes, or they've just been admitted with their stroke. When do we, get excited about a change? And, and practically speaking, when do you wake up Dr. Franco at 2 in the morning and say, there's a problem? Because I will get really angry if someone calls me for no good reason. I'm kidding. But it's one of those things that I'm sure everybody thinks about. So when you have an acute change, again, is this a significant change? Is it a major change? We'll expect a significant amount of fluctuation in somebody's stroke deficit after their stroke. So it may fluctuate. Sometimes we still need to know about that. And if it's enough that it really makes a difference in the patient's ability to use that extremity or that leg or what have you, then that's something we need to think about. Now, if they've already had a stroke and they've already had treatment and we're outside that 24-hour window, then there may not be a lot we can do differently. So to some degree, we have less concern about a small change because it just may not be anything we can do, at least acutely, in terms of interventions, but we may want to intervene in other ways. If the patient's blood pressure is too low, we'll give them a fluid bolus. If we haven't put them on a blood thinner yet, maybe we'll move up that time frame, for example. And I think it's important to keep in mind that patients that we've ruled out for, say, TPA initially because their stroke got better, maybe it was even a TIA, but then they worsen within the first 24 hours, those patients are still thrombectomy candidates if it's within 24 hours, or they are TPA candidates if it's within the time frame of 4.5 hours. So I think that's something that, again, good to keep in mind. Are there medical factors that would explain the changes? Was it something where we just got up and we got hypotensive and that maybe worsened their old deficit? But that should improve fairly quickly. Did we just give them medication? Did we check their blood sugar recently to see if that is unexpectedly high? I just wanted to make sure at some point I covered pupil changes, but that's always one of those scary things that we'll see where, one pupil is blown and, oh my gosh, what do we do? And do we have an aneurysm or a ruptured aneurysm? And, the vast majority of the time, if the patient's pupil has changed and it's asymmetric and one is much larger than the other, if the patient is still talking to you and they don't have a horrible headache or a major deficit, 90+% of the time, if not 99% of the time, it's going to be a medication effect. It could be their nebulizer kind of squirted on one side of their mask more so than the other. It could be an inadvertent contact with an anticholinergic medication. But the biggest thing is if it's different, it's probably something you should let us know about for sure. But it's very helpful to know, do they have other neurological changes that go with that? And then a point about the NIH stroke scale. It's a very important tool. It's a useful tool, but it's a pretty lousy tool to follow someone's deficits in the hospital. And this is because it is different between different observers. The patient could be alert or sleepy, and obviously they're not going to cooperate. And then suddenly we've got a 4-point change in their stroke scale. And what do we do about that? I think, and the other thing is it doesn't affect or doesn't assess the posterior circulation symptoms very well. It's just not very accurate for visual changes. It's not something that can be readily assessed very quickly. I think the bottom line here is just interject a little common sense. Can we kind of understand why the stroke scale changed from the last time it was administered? And even if there isn't a major change in the stroke scale, but there's a definite change in the patient's deficit, then that's something that we need to take seriously, even though there wasn't a big change. All right, so that basically concludes my presentation. This picture is President Woodrow Wilson, who had a major stroke during his presidency, although they did a pretty good job of covering it up, so no one really knew until afterward. But I'll be happy to entertain questions.
Does Fremont have access to the CTA CTP?
I believe they do, and so we can get those images, and I have the ability to get them on my mobile phone. There's an app called the Rapid app that we're able to see that. So and that is the nice thing. And again, I'm not 100% sure, but I believe that they do. But I may defer to Pam. May have that that answer. So we'll reserve the final answer for that when Pam takes the stage.
This is Pam. I'm popping in. All of the Methodist facilities do have CTA CTP capabilities, as well as most of the other facilities in the Omaha metro area having that.
And when, say, we do have somebody that we're actually going to transfer down to the university, it's really allowed us to weed out those patients that are unnecessary transfers. If the CTA isn't positive, we can say, no, they're not a candidate. We'll manage their care where we are.
Can you review again the top most important items you need from the ED, CT, glucose, etc.?
Yeah, so most important from the emergency room. So the emergency doctors are obviously capable of moving through this whole process, and they'll usually call us with questions. But really the most important things to move quickly are, CT and glucose. Now, if we have access to a previous creatinine or that sort of thing, it'll be very helpful. But I think those are still the main things that we need. And then really the history, which is, does the examination show a major deficit? Is it improving? Things about, and then as we all know, getting information or consent from the family or the patient themselves is one of the major kind of slow, that really slows us down, or this sometimes can be the major factor that delays problems. So moving through those processes are important to do as quickly as possible.
If a patient has a drastic rise in blood pressure, but is complaining of the same symptoms as her initial CVA presentation, would this warrant an MD call for a further workup?
Yeah, it does. So, the blood pressure may potentially explain the deficits again, and kind of depends on how often this has happened and what, if we've already evaluated in detail. But I think if we're seeing pretty significant changes in symptoms that are associated with the high blood pressure, you need to let us know about that.
Will an embolectomy be a procedure Methodists would seek to offer in the future?
I think it's something that we're considering. So, finding those particular doctors can be challenging, and we have a good relationship with the university at this point in time, so that we have a rapid way to assess and send images and speak to doctors right away when we need to. But I think we're open to that. So I think it's one of those things, we'll see if that fits into our ability to provide good care to patients.
Little situation here before the question. I had a patient that woke up with stroke symptoms, had a CT of the head without contrast that showed acute ischemic stroke in left PCA.
Good point.
So, okay, sorry. So their last known well time could have been up to 15 hours prior, but I thought these strokes didn't show up on the initial head CT.
Yes, exactly. So there is, the way the radiologists read the CTs, I think you have to realize that there's going to be some variability. You really can't see an acute stroke on a CT. So it's almost an oxymoron or a contradiction in terms. If we're starting to see the changes on a CT, it's probably been at least 12 and maybe 24 hours later. So we really do want to go by the time of symptoms. So we're still going to go by that. Could they have had another stroke that, occurred without any major symptoms that the patient was aware of? Possible. And that would be important to know, because that might be a contraindication to TPA. So basically anytime I see acute stroke on CT, I say, okay, I gotta look into this, because I'm not sure what that means, to be honest. You're appropriate to be confused there.
Let's see. And you might have answered this. I was reading when you talked about creatinine. The question is, do we like to wait for creatinine level in the ER before getting the CTA, or do we do both CT, CTA for signs of LVO?
Yeah, that's a good question. And Pam will kill me if I don't say this phrase, but it's neurons over nephrons. So that's the thing that you have to keep in mind. So basically, like I said, all you need is a glucose and a CT, for TPA. But if we're thinking that this could be a large vessel, we are willing to sacrifice the kidneys to save a patient for a major deficit. Now, again, if the patient's deficit is pretty mild, we're at least want to know if there's a cutoff. There's a point where we're going to be common sense about it and make sure that we don't put the patient at risk for renal failure if we're really not worried about a major deficit. So, but if they have a major deficit, and that's the reason we do the CTA and CTP, we're going to do that, and you do not have to have a creatinine to go forward with that.
Dr. Franco, you spoke of the mismatch between penumbra versus infarct area on the imaging, and that being used to consider thrombectomy outside of the standard window. Is this criteria used to extend the use of TPA outside that window?
Well, TPA is still going to be something that, the typical scenario is someone wakes up with a stroke, and we don't know if that was an hour ago that they had the stroke, or if it was 8 hours ago. There's some thought that TPA could be beneficial if we have that information about the penumbra and the core up to maybe 9 hours, or the last time they woke up. So that is not something we're treating. It's still in the assessment or investigation phase, as far as, is this truly a effective and safe way to treat patients? The data looks like we're kind of moving toward that. And so when we have your wake up stroke, we are going to need to evaluate, or to have that mismatch information to make a decision there. So that'll be important in deciding whether we could extend that window for TPA out to 9 hours. Of course, we still have the thrombectomy capable up to 24 hours, but for TPA, that would be something that would be necessary to make those determinations.
So my portion of this presentation is fairly easy, just because I'm telling my story of the stroke that I had, but I also am trying to be as detailed as I can when I'm talking about it, so you guys can be in my shoes during, so I can take you kind of through exactly what happened. So essentially, we gotta do our objectives first. Okay, so I'm getting too far ahead of myself. We gotta do our objectives. So
I am Pam Stout. I was the stroke coordinator for a Methodist health system, and I am now the stroke coordinator at Emmanuel, CHI Emmanuel. So I thought I would pop over here and have the privilege of presenting with my longtime coworker, Rochelle. So why are our slides not moving? Okay, so first of all, we have nothing to disclose. We're not part of the Cool Kids Club. Our objectives for today is that we're hoping that by the end of our presentation, that you who are listening will be able to identify what a patent foramen ovale is. I will be referring to that as a PFO, because if you say patent foramen ovale too long, it gets tongue twister. Hopefully you'll understand some of the diagnostic tests that we use to diagnose a PFO. Compare some of the different views on closing of PFOs or sealing those up. And then, of course, we want to examine the human experience of a stroke caused by PFO. One, because I think that that kind of brings it home and lets you kind of see from the patient's perspective the effect of stroke. So with that, we're going to go ahead and start and let Rochelle kind of share her story of her stroke.
Yeah, so never in my wildest dreams did I ever think I'd be doing a presentation on this. I do work on the ortho neuro unit here at Methodist, and a lot of times as healthcare professionals, we don't know exactly what the patients are going through, even though we take as best care of them as we can. But unfortunately, I was on the other side of things and was the patient. So I'm honored to be able to share this with everybody. And I think probably some of you have heard my story, but I'm going to tell it again, just because I feel like the more I tell it, the more it gets out there. So my birthday was Christmas Eve, and then woke up Christmas Day, getting ready for work. It was my holiday. And I felt fine getting up, left the house, and I was debating, because I'd been hiding my husband's Christmas present down in our storage unit in town. And I was debating, like, do I stop before work to get it? Do I stop after work? And I just made the quick decision, I'm just going to get it before work, just because so I can come home. That way we could do Christmas that evening with my kids and my husband. So I stopped at the storage unit. I plugged in my code to get in, and it's dark, it's cold, no one's there in the morning. Put up the door to it, and I'm rummaging through it, and essentially it's an 80-quart cooler, so it's really heavy. So I'm lifting it up, and I'm trying to go through the tight space that it's in, and all of a sudden, the left side of it, I just end up like dropping it, and I'm like, that was weird, you know. So I'm at that point still trying to get it out of there, because I'm trying to hurry to get to work. And then at that point, it falls again, and I fall into our snowblower that's in there. So then at that point, it's like everything just kind of stopped, and it was so slowed, and I was hunched over, and in my mind, I'm thinking, what is going on? Is it just that cold in here? You know, I'm trying to, in a little bit of denial in a way, because it's just like, okay, I got to get the heck out of here, you know? And so I'm hanging over, and I'm standing on my feet, and I slowly stand up. And at that point, I'm still trying to get this cooler into my vehicle, and I somehow end up doing that. I don't know how I did it. At that point, though, I felt the heaviness on the left side of my face pull down, and at that point, I just knew I was having the stroke. So I run to my vehicle, and I'm trying to do the smile test, smiling in the mirror, and I'm like, oh my gosh, it's like drool's coming out of the side of my mouth. I can't move my left arm at all. And at that point, I'm thinking, oh my gosh, I need to get to the hospital, but I am literally locked into this place. And I'm like thinking, do I drive? And I'm like, no, my brain told me, no, don't drive. I don't want to wreck the vehicle. So I immediately call my husband first, and he picks up, hello, you know, and I'm like, I'm having a stroke. I'm like rumbling everything together, and he cannot understand what I'm saying, for the point where I was so panicked that I wanted to get the point across. He goes, I can't understand you. What are you saying? And I finally just, in my mind, I'm like, I got to say one word, and I got to say it good, because that way he knows what's going on with me. So essentially I get the word stroke out, and he says, you're having a stroke. And I said, yes. So then he's trying to figure out where the heck I am, because for all he knows, I'm driving to work. And so I'm trying to say storage unit, storage. He's like, where at what storage unit? Where are you at? And then I said school, because he works at the middle school across from our storage unit. So he knew exactly where I was. But just imagine in that point in time, you're by yourself, you're locked into this place. And it just felt like one of those things where you're on like a Lifetime, like one of those Lifetime shows, you're in a dark alley, and you feel like you're being chased, and you're so scared, you don't know what to do, and you can't scream because you're just petrified. And that's exactly how I felt in that moment of time. But at the same time, it was fight or flight for me. I knew exactly if I didn't get help and get help quickly that I would have these deficits for the rest of my life. And then 1,000 thoughts poured through my head of like, oh my gosh, I'm not going to be able to do my job as a nurse, you know, and I refinished furniture on the side. How am I going to do any of that? I mean, my life would drastically change. And so I just was like, okay, in survival mode. So at that point, when my husband knew where I was calling 911 and I'm panicky. I'm just like, just get somebody here, you know? And of course I'm thinking, how the heck are they going to get into me? But I wanted to let them know my last known well time, because at that point I just knew if I were to go unconscious or something crazy, they just would know my last known well time. So the 911 operator was very good. And I, of course, being a nurse, I'm thinking, well, I got to let work know I'm not going to be at work today, you know, and it was kind of a crazy thought, but at the same time, I'm thinking they have to go on with their day. And so 911 actually offered to call work for me, which I was actually surprised. But anyways, then I see the headlights of my husband's vehicle, but he wasn't coming. And I'm like, why isn't he coming? Why isn't he coming? You know? And he gets to a point where he is so flustered trying to punch the code in. He was trying to do it so fast, it would not open. So he scaled this 10-foot fence or the gate to jump in to come to me. So when he opens the car door and looks at me, he knew exactly, yes, she's having a stroke. I need to get her to the hospital. So at that point, I'm like, we're in the vehicle. I'm not going to wait for an ambulance because, like Dr. Franco said, time is brain. I mean, the longer you wait, your brain cells are dying. So we ended up driving, and then I saw, and of course, where I live, they have a volunteer fire department. So they were still on their way to the ambulance to get the ambulances, but they had the little cherries on top of their pickup, and we flagged them down and just said, hey, this is us. We're just going to go to the hospital. So we drove like probably 100 miles an hour to get to Methodist. And at that point in time on the way there, I was able to call our floor. My husband helped me talk, of course, but saying I was having a stroke, that we're coming into the hospital. And then our night charge nurse, she said, you know, I'm going to let the ER know you're coming just so they can be ready for you, which I was so thankful it happened that way. But kind of a funny part, we pull up right in front of the hospital, and I'm kind of running in thinking, oh my God, my leg could go out at any time. And I'm running through the front door, and I'm telling the first person, I'm like, I'm having a stroke. And this guy looks at me like I'm kind of crazy. He goes, oh, I'm so sorry, you know, but he didn't work there. He had just dropped somebody else off. So then I'm looking around trying to find anybody just to get me back to the ER. So our ER staff responded so quickly and took me back and ran me through all the tests and ran me through the CAT scan. And initially they were thinking it could be like a complex migraine, but honestly, in my life, I've never had a migraine. But all I know, I just kept saying TPA, I need TPA. They ended up administering the TPA. And at that point in time, I'm just trying to do like the smile test, you know, I'm trying to move my arm. And I'm thinking, oh my gosh, it's not working. But when the doctor kept coming in, doing his assessments, he's like, wiggle your finger, you know, and I would look down, and my golly, my thumb was wiggling. I could actually somewhat smile. I could talk better. And at that point, my symptoms resolved, thank the Lord, because there's some patients that it doesn't, I mean, they're not as fortunate and it doesn't work. But honestly, I felt like I could have gone back up to work that day. I mean, I literally have no deficits. And at that point though, they had already contacted Nebraska Medicine because they wanted to, they were going to possibly do a thrombectomy on me. Where my clot ended up being was in my right middle cerebral artery. Since my symptoms resolved, they still wanted to send me there just to make sure everything was gone, the clot was gone. They ran me through a CTA, and then they did the perfusion study as well. And at that point, they decided that were not going to do the thrombectomy because the clot was gone. But so yeah, it seems like a blur, and I can't believe again that I'm be able to talk about this, but it's just, stroke is real, and I can't imagine some of the patients that have lifelong deficits because it is very debilitating. And again, I didn't have any type of rehabilitation. I only had to stay in the hospital over the weekend because of course Christmas was on a Friday, and then a lot of the tests they wouldn't do till Monday. And so I had to stay the weekend. But at that point, they run a gamut full of tests, which Pam will talk about more in detail, but they try to find out the source of the stroke. And what they ended up finding with my situation, they did a TTE, a transthoracic echocardiogram, and then they also did a TEE, transesophageal echocardiogram, which found that I had a PFO. And Pam will talk more about that right now in detail.
So one thing I want to say is on Christmas morning, when you wake up and the first text is from somebody that you've worked with for as long as I've worked for Rochelle, or worked with Rochelle, and Rochelle says, I've had a stroke, I got TPA, I'm at Nebraska Medicine, no thrombectomy needed. At first I thought she was joking. And then I immediately called her to make sure that she was okay. And so we often wonder why things happen. And we will never know for sure why, of all the people in the world, Rochelle had to have that stroke that morning. But when I knew that she was okay, I said, we will be using your story to spread the word of stroke. And I think one of the key things with Rochelle is the fact that she is young and she is healthy. And hopefully it makes everybody who is listening today recognize that stroke is not something that only occurs in the older population, but it can happen to anyone. It does not discriminate. So we're going to kind of go in and talk a little bit now about PFO. I am by no means an expert in PFOs, but I have done some research and am going to share what I have learned, and hopefully you learn something from this. So we're going to start a little bit with anatomy and kind of the source of a PFO. So we need to start a little bit with fetal circulation. In the uterus, okay, there is a typo on this, and I'll explain it when we get lower. She just had to point it out to me. In the uterus, the oxygen and nutrients are delivered to the fetus via the mother through the umbilical cord. When it travels in through the inferior vena cava, it goes into the right atrium of the heart. It doesn't go to it doesn't kind of follow the same path that it does as an adult. It actually will travel from the right atrium directly into the left atrium via an opening or a shunt called the foramen ovale. However you'd like to pronounce that, foramen ovale. And from there, it's then pumped into the ascending aorta to be sent out to the brain, to the heart muscle, as well as to other parts of the body. Once the child is born, the umbilical cord is then clamped and the baby takes their first breath of air. This is the typo. We've changed it 3 times. Not sure why it didn't change on here, but the lungs expand. And when that happens, these openings that are created to kind of travel to get that oxygenated blood and those nutrients then begin to close. So the foramen ovale starts to close once that first breath is taken, which ultimately will result in the circulation functioning that we have as adults. 75% of people will have complete closure of the foramen ovale by the time that they're 2 years of age. Think 75%. So in a perfect world, once that closes, or once we take our first breath, this is kind of the circulation that takes place in the heart to kind of oxygenate the blood. So the blood from the body that's oxygen poor is pumped into the heart via the superior vena cava. From there, it goes into the right atrium, traveling through the tricuspid valve into the right ventricle. And from there, then into the pulmonary artery, taking it to the lungs where the blood is then oxygenated. It then comes back to the heart via the pulmonary vein to the left atrium, through the mitral valve and into the left ventricle, and then into the aorta, or through the aortic valve into the aorta. And at this point, that oxygenated blood is then distributed to the brain, the heart muscle, and the body, and the cycle continues. And it just kind of goes on and on and on and on in a perfect world, and we never have any problems, right? Well, we know that when somebody has atrial fibrillation, the heart's not pumping like it should, so blood can pool in that left ventricle, and when blood pools, it starts to coagulate. And so then we can end up having that clot that can then get shot out, causing stroke or heart attack, because that clot is there. So what happens when the when the patent or the foramen ovale does not close? We then get a patent foramen ovale, and this is in approximately 25% of people. It doesn't close properly. So what happens is rather than it getting sealed. So think about when you scab your knee and you get a scab, something is sealing that opening, right? So when your foramen oval seals, it's sealed with like a thin covering, and it normally seals all the way around so that no blood can pass through that. But in a PFO or in a patent foramen oval, that flap or slit does not seal all the way around. And so that can allow that oxygen poor blood to flow from the right atrium and mix with the oxygen rich blood in the left atrium. In normal circumstances, you have such high pressure in your left atrium that it pushes against that flap, and it prevents this from happening. So it prevents that blood from flowing. However, sometimes there are actions that we do without realizing that we're doing it that can kind of prevent that seal from completely occurring with each contraction. So if somebody has a Valsalva maneuver, such as, when they're having a bowel movement, when they're vomiting, or in like Rochelle's case, she's picking up something that's heavy. So maybe she's straining to pick that up. That opening does not seal. That flap doesn't completely close. So what this allows is to have some kind of a right to left shunt that can potentially lead to a paradoxical embolism. So it allows some kind of an embolism to kind of pass through that without kind of being filtered through the rest of the process. Therefore, that clot can then travel. So in this image here, this is just kind of a blown up graphical image. You can kind of see where that red, the red and the blue arrows are. When you have that flap opening, that oxygen poor blood can travel, and it can actually go the opposite way as well. But blood is traveling where it should not travel. And then in the bottom area, where that area was, that's just kind of showing you that flap. So that flap is left in place. Generally, pressure will kind of hold it against it so that that blood doesn't travel. But in those instances where we strain, we sneeze, things like that, that flap can open just enough for blood to be able to travel through that hole. And yet here's another picture, because I like pictures. To me, that's how I learn. You can kind of see on the left side, that's the normal traveling of the blood, right? And in the right side, if you kind of notice where I've got that yellow circle, that's blood that should not be traveling that direction in either atrial septal deficit or in a PFO. So blood is traveling where it should not travel. So what are the risks of PFO? Generally, you don't have any symptoms. There is some thought that maybe it plays a part in migraine headaches. I couldn't find anything that conclusively said, yes, if you have a PFO and migraine headaches, that's the link to it. But there is thought that maybe it is part of that process. There is an increased risk of stroke, transient ischemic attack, and heart attacks, as well as DVTs. However, most people with PFO never have any symptoms, never have any negative consequences of the condition. When somebody has an ischemic stroke, especially if they're under the age of 55, so if they have an ischemic stroke and we can't identify what the risk is, so we're not finding that they have hyperlipidemia, they don't smoke, they don't have diabetes, they don't have high blood pressure, we really need to do a really thorough evaluation to determine what that cause is of that cryptogenic stroke that they just had. And what they found is that people under the age of 55 with a cryptogenic stroke, they are more likely to be diagnosed with a PFO throughout that study. It may be an incidental finding, it may not be related to the stroke itself, but that's kind of what the studies are showing. So if the pressure on the right side of the heart increases, blood clots or solid particles from the blood may move from the right side to the left side, as I mentioned a moment ago. When this occurs, the clot can travel to the coronary artery, causing a heart attack, or it can travel through the aorta into the MCAs, your cerebral vessels, causing either TIA or ischemic stroke. Remember, a TIA, the symptoms are fleeting, so they don't stick around for a long period of time. I think that they said that the average duration of a TIA is less than 5 minutes, and your body does what it's supposed to do. The clot moves on, it breaks down. Or in an ischemic stroke, where that clot just kind of sticks there until we do something about it, we're preventing that blood flow from occurring. One of the things that they found, just as a side note, is that when they started doing MRIs on a lot of TIAs, people that we think are TIAs, they actually do find evidence that they've actually had a stroke in that location. They just have really good collateral circulation, bringing blood flow to the area of the brain that's that blockage is at. And then, as I mentioned, patients with a PFO are more likely to develop deep vein thrombosis for that same reason. That clot can travel and kind of goes wherever it needs to go, goes along with the flow of the blood. So we need to evaluate what the cause of the stroke is. So we're going to check your hemoglobin A1C, make sure you don't have diabetes, or that if you do have diabetes, that it's well controlled. We're going to check your lipid level. We're going to find out, we're going to do carotid studies. We're going to look to make sure that you don't have a lot of plaque buildup in your arteries. We're going to, if you have atrial fibrillation, we're going to, make sure that we're taking the steps that we need to prevent recurrent stroke. I think it's important to note that 25% of strokes are happening in someone who's had a previous stroke. So it's a 25%, 1 in 4 stroke patients will go on to have another stroke. Within that workup, we're looking at carotid studies to look for sources of the emboli. So as Rochelle said, she had a TTE, that transthoracic echocardiogram. So that's the echocardiogram. That's an exterior ultrasound, basically, of your heart that they're doing, and they're watching the blood flow through. And then they may do a transesophageal echocardiogram, which gives a much better picture. That's generally done under like a twilight anesthesia, and they take the probe down your esophagus. So when we're looking at the studies that are done, they may do a color flow Doppler. And that's where they're looking at red blood and blue blood, so oxygenated blood and non-oxygenated blood, and they're watching that flow to make sure that it's following the path through the heart that it should, and that it's not crossing over. Or they may do a saline contrast study, otherwise known as a bubble study, and that was what the video was of. But basically what they're watching is they're watching these little micro bubbles kind of travel through. So they're injecting an agitated saline, and they're watching that. And it takes a few cycles usually for them to see it, but they're watching to make sure that the bubbles are not crossing basically at the septum or at that where the PFO would be. So Rochelle, they did the saline contrast study on you, correct?
They did. And it was pretty interesting because, like I said, I was watching the monitor the whole time, and they did the agitated saline and they said, ready, go, and they push it through, and you literally on the screen, it looks like a blizzard. It literally is in the atrium, but then you could see with my case, you could see those bubbles going to the other atrium. And it's pretty interesting to see that I was awake enough to be able to see that, but
Leave it to a nurse. We're always going to learn, right?
yeah. So yeah, it was interesting.
And one of the things that what I've read is that the risk of your PFO being associated with the stroke that you had is higher the more bubbles that can cross over. So you may have a PFO with just a couple of bubbles that pass through. Those are not necessarily considered to be or thought to be high risks of those stroke. But if they get more than 20 to 30 of those micro bubbles that pass through with each contraction, that's when they're considering that this may be the cause of that stroke. And I do apologize that the video was not working. It worked when I was at home. Evidently, I logged in at home. Well, there's the picture of it. So I don't know if you can see the mouse on the screen or not, but you can kind of see in the left atrium, and then when it contracts, the bubbles are going to pass through here if you have that PFO. So then if they discover the PFO, they're trying to determine was that related to the stroke that you just had, or is this an incidental finding? So they have this risk of paradoxical embolism, or the rope tool. And so they look at your characteristics. Do you have a history of hypertension? Do you have diabetes? Do you have a history of stroke or TIA? Do you smoke? And is there a cortical infarct on imaging? You get points for those things if you have them. And then they look at your age. And if you notice on the scale, 18 to 29 gets the highest number, because most 18 to 29-year-olds should not have a stroke, because generally they shouldn't have all these other risk factors. However, we are finding that that's not necessarily the case anymore. But as you age, you end up having less of a chance that that PFO is related to your stroke. So Rochelle, being in her 30s, having just had a birthday the day before, she would have scored 4 points for her age. And that helps them to determine if that PFO is directly related to the stroke or if it is just an incidental finding. Important to know that the ROPE score does not indicate the risk of having another stroke or TIA related to the PFO. It's only looking at, you've had a stroke. Let's look at the score to determine, was a PFO related to it? So once they determine if you have a PFO, the question comes in, do we manage this with medicine, so anticoagulants, antiplatelets, or do we go in and we close it? So Rochelle, did they have a lot of discussion with you on this as to what should you do? They give you a lot of options?
So the options they told me is, my neurologist basically kind of laid it out and said, so you had this stroke. So the chances of you having another stroke is 4% if you don't close the PFO. But he said, I'm all about percentages. And if you can lower your percentage even by a few points, he goes, why not do it? But he also said, but there's no right or wrong answer. It's such a low percentage. But here I am, I'm young and I have no other risk factors and I didn't want this happening again. So I went through to have my PFO closed, and essentially the risk of having another stroke is down to 2%. So I thought, well, it's not by a significant amount, but it's lower, and I was willing to take that risk. So I ended up having mine closed. So there are different views on whether or not a PFO should be closed, because again, we don't know if the PFO is just an incidental finding in some cases, or if it was a direct cause, or if it's going to increase your risk, because how often are you going to have those Valsalva maneuvers or those things that could increase the chance of that flap opening? And I will say that I'm going to kind of give you two different scenarios here. The first one is, why should we close this? There are multiples of studies, well, 3 major studies that I looked at that kind of talk about why we would want to close a PFO. Sorry, I'm just trying to open my notes a little bit more here. So why would we want to close it? So the RESPECT trial, this looked at patients who had cryptogenic ischemic stroke. So again, these are ischemic strokes, so they had a blockage, but we could not identify why they had that stroke. But they identified that they had and so throughout the workup, they found that they had a PFO. So they looked at closure of the PFO versus medical therapy. And the medical therapy that they were looking at were antiplatelets, so aspirin, Plavix, versus anticoagulants, so warfarin, Eliquis. And they kind of wanted to compare and say, which is better, which of these patient groups are gonna be more likely to have recurrent stroke. What they found is that those patients that they closed had fewer recurrent strokes at 3.6% than in medical therapy alone during the extended workup. And they followed these patients for almost 6 years. So 5.8% of the patients that were in the medical therapy alone, 5.8% of them went on to have another stroke. And then they always try to figure out, so because this was a study to kind of look at the closure. So they wanted to know, how many patients do we need to treat to reduce the chance of preventive stroke, or preventing that secondary stroke. They determined that 42 patients needed to be closed to be able to make that one patient not have that recurrent stroke, if that makes sense. And when they close, what they're doing is they have a device that goes in, and it's basically got 2 mesh or wire mesh on either side, and they go through the PFO. One goes onto the left atrium and the other side stays on the right atrium, and then they seal that up. So basically what they're doing is they are manually closing that flap to prevent it from being able to open. So that's what they do when they close it. The REDUCE trial looked at PFO closure versus medical therapy with only antiplatelets. So we're not looking at anticoagulants.
They studied 664 patients for approximately 3.2 years. And what they found is that when they closed it, the chance of those patients having a stroke, it was like 1.4% had recurrent stroke versus the medical therapy of 5.4. And the number to treat patients in that study was 28 patients. And then the closed trial, this again looked at PFO closure versus medical therapy with both antiplatelets and anticoagulants, and they studied 663 patients over 5.3 years, a little over almost 5.5 years. And what they found is recurrent stroke occurring did not occur in those patients that they closed, and then those patients with antiplatelet therapy alone were about 5.9%. And they found that the number to treat was even lower at 20 patients. But one of the other nice things that they did in the closed trial is that they looked specifically at the medical group alone. Now, remember, they were looking at antiplatelets and anticoagulants. So in the, they kind of looked at the difference between the two. Gotta find my note here, sorry. And they didn't find any difference if they treated the patient with an antiplatelet versus an anticoagulant. It was still roughly a 5.9% chance, regardless of what they were treating them with. So then why would we not close? And I think that in most of the studies, and Dr. Franco can probably chime in on this as well, but in most of the studies that I looked at, it wasn't a question of to close or not to close. It was a question of who really requires closure. And to summarize the studies that I looked at, not all patients with a PFO will experience a stroke or a heart attack. In stroke, a patient needs to have a thorough evaluation to evaluate, for structural cardiac disease, heart valve disease, cholesterol levels, hypercoagulable workup, cardiac arrhythmia, to identify if the PFO is the only cause or if it's a contributing factor. If no other contributing factor is found, then we need to consider closing the PFO. If other factors are determined to be the cause of the stroke, the PFO may be an incidental finding and not require that closure. But ultimately, research shows that closure of PFO has its place in carefully selected patients. So really having that partnership between the neurologist, your stroke neurologist, and cardiologist. And Rochelle, can you kind of chime in? So you met with your neurologist who kind of supported giving you the facts of the PFO closure, and then you went and met with the cardiologist too, correct?
Correct. And either way, like I mentioned about the percentages, they kind of just throw it out there for you and just say, these are the percentages, and either decision you make is a good decision. I mean, you're young or whatever, but then I'm like thinking, I don't want this happening again, So I made the decision to close it. And then also I'm on a baby aspirin every day as well. And that also is debate as well, since I've had it closed. He advised me, if I was in my 70s, he would definitely say to take it. Obviously if I'm 18 years old, no, don't. But he's like, you're in that middle-aged range where it's like, well, if you can tolerate taking one, that's fine. But if you're having some bleeding issues with it, it's fine as well. So I've just chosen to take it just because I, again, don't want it happening again.
Once you've had a stroke, you don't want another one, evidently, is what we're learning.
Yeah.
And Rochelle, the next thing I kind of want to do is kind of talk a little bit about your closure and kind of your next step. So you were in the hospital for 4 days. They found that you had a PFO. So what was the process? Take us through the process of your deficits were thankfully resolved and you didn't have deficits. Did you follow up with therapies? Did you kind of walk us through that process, and what was the timeline from the time that you had the stroke to the closure?
So essentially being in the hospital, they had PT and OT come evaluate me. And essentially that's when I was in the neuro ICU. I essentially stood up, walked down the hallway, and I didn't want to be cocky and do a spin, but I mean, I literally, like I said, felt normal, and then they signed off right away. And then
all complete work.
Yeah. And anyways, and then they did Dopplers of my lower extremities because they want to make sure the clot didn't maybe come from, my lower legs or whatever. And that was negative. They did a ton of lab work to see if I had a coagulation disorder, and that was fine. So then that's what led them to do the echocardiogram and then the transesophageal echocardiogram that Monday. But come to find out, they did say that my PFO, I mean, it wasn't the worst that they saw, but it was a significant amount where they called it aneurysmal, where it kind of just flapped. It was just flapping around. So it's like, I want to close that. I don't like that. So essentially, I think it was 2 months later is when they ended up closing the PFO. And essentially it was kind of a twilight, but again, I was awake during the whole procedure, and it was pretty interesting because they pump some heparin through you while they're doing it. And then at one point I felt my heart fluttering around, and of course they're in there. So I was like, I feel weird or whatever. And he's like, well, yeah, we're in your atrium. You're probably having some PVCs, but that was an experience in itself too. But it went through my groin, and I don't know, it was pretty painless. It was in and out type of a day, and I was done. So now you left the hospital, you had a Zeo patch, so they were monitoring your heart.
Yep.
And they were doing that because they wanted to make sure that you didn't have atrial fibrillation.
Yep.
Correct? Yep. So when I left, thank you for reminding me of that. So when I left the hospital, I did have to wear a Zeo patch. I think it was for two weeks. Then I had to send that in, and they of course said everything was fine with that. I never went into AFib. So they did a really thorough exam and everything to figure everything out. So that was why thinking, well, if I have a PFO, that had to have been where the clot went through. So okay. Yeah. And Rochelle, if there was one thing that you could tell everybody that's listening today about stroke or about your experience, what would that be? I think more so, I mean, take it seriously. Don't ignore things. I think it's easy, especially with, I'm young, I'm healthy. So initially, I think for a few seconds, I was in a little bit of denial because I thought, well, I can't be having a stroke. I don't have time for this. It's Christmas. I got to come home tonight. I got to do all this stuff. And it happens to anybody. I mean, stroke doesn't just, happen to the elderly people. It happens to young people too. And just pay attention to the BFAST symptoms, because some of those, the balance and even like the visual things, I think some people would play it off of like, oh, I'm just tired, I'm stressed, I'm just going to go sleep. No, you need to take it all seriously. And it's better to, I guess, err on the side of caution and get it checked out rather than just ignore it and then have lifelong deficits. So that'd be my advice. And I think that most, any of the stroke coordinators that may be on the call from any of the systems, or you as a nurse who's taking care of a stroke patient, the saddest cases are the ones that the patient has a devastating deficit, one that's going to change their entire life. They may not be able to do the job that they do. They may not be able to take care of their family. Those patients who have those deficits because we were not able to treat them because they did not arrive to the hospital in time, I think is one of the biggest things to think about, and one of the important things why we need to be educating all patients, our loved ones, our friends, our strangers, the people you don't like, because you don't want to have to take care of those people, right? All of those things, make sure that people know what BFAST stands for, and to be able to identify a stroke and get to the hospital ASAP, go to the closest certified hospital. In the Omaha metro area, we are very, very lucky that every hospital is a certified stroke center. So if you come to a stroke center, and I know Dr. Franco talked about the RACE score, and the RACE score is used a lot of times by EMS to help determine where that patient needs to go, whether they need to go to CHI Emmanuel for thrombectomy or to Nebraska Medicine for thrombectomy, or whether they can go to a primary or an acute stroke ready hospital to receive IV alteplase. If you go to a hospital that does not do thrombectomies, we can still give you IV alteplase, otherwise known as TPA, and then we work on getting you transferred to the center that you need to go to. The best thing that we can say, as you could tell in Rochelle's case, is getting that IV alteplase started as soon as possible, because if that can break up the clot, you may not need the mechanical thrombectomy. If you get here too late and you're no longer a candidate for mechanical thrombectomy, or I mean, too late, but you're no longer a candidate for IV alteplase, we can help get you where you might be able to go if mechanical thrombectomy is a choice. So really make sure that you are ensuring that your patients are aware of those. And again, 25% of patients go on to have a second stroke. So we want to make sure that they know what to do if it happens again. But let's kind of summarize a little bit about this, and then we'll kind of get to questions. Foramen ovale is important in fetal circulation. That's how we get our nutrients as a fetus. Complete closure of the PFO is obtained in 75% of people. 25% of people may have an incomplete closure resulting in a PFO. So 1 in 4 of us
may have a PFO right now that are listening to this. Most of us would not have any complications of that PFO. But if you are one of the folks that do have a complication, it's important that if we cannot identify your cause, so it's a cryptogenic stroke, that you undergo the correct diagnostic test to determine if that PFO is present, and that if that is that a contributing factor to your stroke, and does it need to be closed. Common diagnostic test for PFO is the echocardiogram with a bubble study. I think that's what most centers do. There may be other studies. And then closure of the PFO has been linked to a decreased risk of recurrent stroke. That does not mean that everybody who has a PFO requires closure, nor does everyone who has PFO and a stroke require closure. And one thing that I didn't share when I was talking about the closure is that there is an increased risk of developing atrial fibrillation when they're doing that PFO closure. And so that's one of those things that they kind of have to look at when they're making that determination. But I think that's what we have. So we're going to go ahead and leave this open for questions, but those are my references. And again, if there's questions that I can't answer, we're going to look to Dr. Franco to kind of jump in and help answer those questions.
The first one, can you clarify why PFOs in cases without other risk factors are considered uncertain significance and classified as cryptogenic strokes versus classified as cardioembolic strokes?
So I think that some PFOs, again, remember that rope score that they do, they're trying to determine, did that PFO, was that a contributing factor or not? Some PFOs are small. The clots aren't going to travel through. And Dr. Franco, I'm sure that you can kind of chime in there on the classifications, as well as why would it not always be considered as a contributing factor?
Right. It has a lot to do with the fact that the PFOs are so common in the general population that we just can't make an assumption that that was the cause for the stroke. And so we're still going to kind of call that a cryptogenic, meaning we don't know for sure what the etiology was, as opposed to if you have atrial fibrillation, then we're going to consider that an embolic stroke. There's situations where you see a PFO, and in Rochelle's case, it's like, this is pretty obvious. You know, she's young, she doesn't have a lot of risk factors. You know, the PFO also had that aneurysmal change. That means that the wall between the two atria is kind of mobile, and that increases the risk as well. So there's all these little factors that play into it. And then you have to have a clot or something that forms in the venous circulation to get a stroke from through your PFO. So as you're, we also have to consider that as something to investigate. But for the most part, it's just really prevalent and very hard to know for sure if it was directly related or not.
Thank you, Dr. Franco.
Is the bubble study something that we do at Methodist, or is that something they must do at UNMC?
The TTE and the TEE with bubble study can be done at any of the facilities, pretty much across the Midwest. I don't know of any of them that can't do that.
The MTHFR mutation, are healthcare givers watching that as a risk factor and educating families if they have detected that? Yeah,
I can speak to that a little bit. That one's a little bit of a controversial topic because there's different levels if you have both, if you're homozygous for both alleles and all that. So it's hard, and it increases your risk for arterial stroke. So, a little bit different than the PFO conversation because it's really a clot in the venous side that gets through abnormally to the other side. But yeah, we're watching for that. The insurance has made it very difficult to test for that routinely. We can get some clues from the blood work as far as the homocysteine levels, whether or not you'd be at risk for that. And it's not considered a very potent risk factor for stroke, I think, and so even if you have it, we sometimes don't do anything different other than really watch closely. And, we're not going to necessarily put you on anticoagulants, for example. So that was an evolving understanding, I think.
Thank you. Is there a significant link between chiropractic care and vertebral artery stroke?
There is, it's kind of a risk factor, but it's not something that I would go in being concerned about. Maybe it's because I'm a stroke neurologist, but I probably not going to get my neck manipulated. But the thought is that with very forceful movements of the neck, quick movements, we could have a stretching or tearing of the inner lining of the artery, which typically is the one that's most susceptible is the vertebral artery, which runs up and down your spine. But the same risk could occur with a car accident, a roller coaster ride, you fall or bump your head on the top of a doorway or something. So anything that jerks your neck quickly is a risk. Do I see strokes due to chiropractor manipulations? No, I think I could count on two fingers where it was questioned, I think. So it's not something I would really worry about. Just like you avoid everything you can to avoid a risk for stroke, just forceful manipulations of the neck, I think, are something that, depending on your age and stuff and the type of problem, you just want to keep that in mind.
How significant is OSA as a risk factor for stroke?
I think it's a big risk factor. I think it is hard. It's not quantified very well. A lot of people with OSA may have all other risk factors, whether it's diabetes or obesity or things like that. But it's definitely considered a significant risk factor, both for stroke and for heart disease. In addition to the lung problems it causes, and so it's a big, and we see an increased risk for seizures. So it's definitely, I would consider in that sort of secondary group of risk factors. So it's definitely there.
Any other questions from the audience right now?
I maybe just want to reinforce one of the things that Pam said, which was, when we're trying to decide whether to do these PFO closures or not, like I said, in Rochelle's case, it's pretty clear. Again, I would have done the exact same thing if I were her and that was my situation. There's a lot of times it's less clear. And the downside is that, just like, Rochelle felt that fluttering of her heart when she had the procedure done, there is an increased risk for atrial fibrillation as a long-term consequence of the closure. And in the initial studies, were maybe 5%. So we were it was almost a wash. You're closing it and reducing your stroke risk in one way, but you're increasing it in another way. But they've gotten that to be a lot better. So now the risk of atrial fibrillation appears to be much better based on the devices they have to do the closure. And so we're looking at those AFib risks as, maybe 1% or so. So again, but it is something you think about when you're on the fence about whether or not we should be doing this, or you find a PFO in someone who's in their 70s, and that changes the dynamic of how likely the PFO is responsible.
Pam, you were talking about how important it is to train our family and friends at being quick and getting to the hospital quick if they recognize any of these symptoms. In big cities, we're very lucky, but how about for family and friends that we might have in smaller, more rural towns that don't have access to our large hospitals? What are some things that maybe they can do to help the healthcare providers there act quickly and maybe do some testing faster than maybe they would be inclined to?
So I think in the state of Nebraska and in the state of Iowa, there's a big push towards the systems of stroke care. And a lot of work is being done in critical access hospitals and in the rural volunteer fire EMS providers to make sure that a lot of critical access hospitals do carry IV alteplase, and some of them will give IV TPA, the alteplase, making sure that the EMS are using the appropriate screening tools for stroke and alerting the hospital. One of the big things for EMS, and one of the things that any coordinator that goes out and does education with EMS will tell you, is that we really hit home on, we need to know last time known well. We need to know what medications they're on. So if they don't have a list of it, bring them all in, all the meds with you, so we can determine if they're a candidate for different things. But knowing that last time known well. So really making sure that the community understands why that's so important is a big deal. And critical access hospitals. So in the state of Nebraska, we have put together a toolkit under the American Heart Association Mission Lifeline Stroke process that we're in the process of, where they have access to primary stroke center neurology phone numbers. A lot of them have teleneurology, so that they are getting that quick workup to determine. A lot of the critical access hospitals, they rely, because they're so far away from the comprehensive or the thrombectomy capable center, they rely on flights to get the patient there. So if they know that there's a stroke coming in, a lot of them will automatically kind of initiate that process. So the helicopter's getting ready, the ambulance is getting ready. And as soon as they come in, they do the quick workup, and then they ship them out. So that is something that's big, but probably the best thing for the community to know is why it's so important for that last time known well, identifying those symptoms and making sure that we're giving that valid report when we're calling what's going on with that patient.
Great, thank you. Dr. Franco, can you address the difference between transient global amnesia diagnosis and stroke? How are they different in their symptoms?
Yeah, it's a good question. Transient global amnesia is kind of one of my favorite diagnoses, in part because it always goes away and the patients are fine afterward. But the only thing that's wrong in a patient who have transient global amnesia is they suddenly have an inability to remember what's going on at that particular time. So they usually will kind of remember, that they live in a certain house. They remember who their spouse is, but they have no idea what they were doing that day, and they have no idea what happened yesterday. Maybe they don't recognize furniture in the house that they just bought. It's kind of a very bizarre thing, and it happens just suddenly, and it may last for several hours. But during that time, and you'll be explaining questions to them, and you'll say, we're going to the hospital because it looks like you're having a problem, you're confused. And they'll nod and say, and then about 20 seconds later, so why are we going to the hospital again? And they will repeat that because they just can't remember anything, literally. But everything else works fine. So their speech sounds fine, they're alert, they move everything. If they had to drive somewhere, they could drive and navigate the car, things like that. They just really don't remember what happened over the last, 24, 48 hours, and nothing is sticking at that point. And then it gets better. As opposed to a stroke, it's a problem with speech. They can still, if they can speak, they can still remember what you just told them a few minutes ago. And there are oftentimes other symptoms. So it's different than a language problem or a dysarthria. It's a pure memory problem, which fortunately the memory is present on both sides of the brain. So you can't really get your memory with a stroke. So even people who've had huge strokes, their memory seems to be fairly well preserved.
How long does it take for the mesh wire to epithelialize in the heart? Is there additional need for short-term anticoagulation after the procedure?
So with my experience, and I don't know if this has any correlation with it, but it's just like when you have like a joint replacement, you need the antibiotics after the procedure. They basically told me I needed to wait like 6 months before I'd go to the dentist. So I don't know if it's at that point, the 6-month mark. I can't say for certain, but with my experience, they'd put me on Plavix. I believe it was for a month after my procedure. And then I'm just on the baby aspirin now, but the Plavix they put me on additionally for an extra month.
Yeah, I don't know if you know, Pam, I don't have a firm time frame. I think it's, for like the Watchman procedures, they're often, anticoagulating for a certain period of time afterward, because we're not even sure whether anticoagulation is necessary in the PFO situation. And to begin with, there's no standard, but I think once that closure is done and that device is there, we basically have eliminated that risk. And so we can treat it as if the PFO is not there, even though it'll take probably a month or two for it really to secure in place, for example.
Yeah, in the research that I was doing, I didn't see anything that said you need to be on something for this period of time or how long it takes. But I was more looking at the studies of why do we close versus not closing.
Right, and if we did have a venous clot, like a DVT, we're gonna, then we may be anticoagulating for that reason. And, maybe, then we're looking at 3 months. So if there's a separate indication, you can, but if not, it's probably not essentially necessary just for the PFO afterward.
And Rochelle, were you on like Lovenox or anything in the interim between the time that you had the stroke and they found the PFO and when they did the closure?
Oh, gosh. No, I wasn't on Lovenox at home. No,
So-
just the aspirin.
And I have talked to some other people that have had the PFO and they were on Lovenox until they had it closed. And then they were on Plavix, I think, for about a month to 6 weeks afterwards.
Thank you. Rochelle, this question is for you. What would you change or do differently now that you've gone through this experience?
Oh, what would I change? I don't honestly feel like I would change. Maybe calling 911 first. That probably would have been the best thing instead of calling my husband. But I was thinking my husband can get me out of here. But then in fact, he was so frazzled himself, he could. But I mean, maybe calling 911 first so they could have gotten, especially being a volunteer fire department, they could have gotten there maybe a little quicker. Then what was the second part of the question?
Yeah, it was just what would you change or do differently since you've been through it?
Honestly, I think by the time I got here, as quick as we drove, I got TPA within how many minutes?
42 minutes.
Yeah, 42 minutes from when I came in the door. So, I mean, I feel like it happened. I mean, I'm so thankful I didn't wake up this way. I mean, I knew exactly when it happened. And I don't know if I mentioned this, but like you assume sometimes with strokes, like Dr. Franco kind of hit on it as well, that like, oh, maybe they're confused. They don't know what's going on. But in my mind, I knew exactly what needed to happen and when, it's just all my thoughts were there. I was just trying to get them articulated and spit out and, was the thing. But I don't think honestly I would change anything because I think it happened the way it was supposed to. And I have actually the perfect outcome, whereas a lot of people don't have that. And strangely enough, my sister-in-law, which is my husband's sister, who's the same age as I am, less than 2 months, had a massive stroke. So it hits home, but and she just got home after 5 months of rehabilitation. So, and she's got, her right arm is completely flaccid still, and she's having aphasia issues. So just with my incident and then hers, it's really hit home with stroke of how important it really is to get help as quick as you can.
Absolutely. We have, in response to our previous question, cardiology usually tells patients 4 to 6 weeks for endothelial cells to form. So they would be on anticoagulants for that time frame.
I just want to say thank you to Rochelle for being open and willing to share her story. I really do feel like when you know somebody, when somebody that you're close with has had a stroke, it just brings a different awareness. And I will, even though I'm no longer with Methodist, I will continue to use Rochelle and her story as I move forward in the stroke world. So,
Yep. And I just want to thank everybody for taking the time out of their busy days to listen to us as well. So it means a lot to keep telling my story. I feel like if it can help one person, we've done our job. So.
Absolutely. Thank you so much, Rochelle. And the more we get the word out, again, before people have strokes, obviously that's where the biggest benefit is there. We just haven't really taken advantage of that completely yet.